We'll be introducing our next session, which is LH1 and LH1 Plus, an overview, and I'll pass it to Alyssa Poinsano.
Thanks, Jessica. Welcome, everyone. Glad you're all here. I'm Lissa Poinsano, an unaffected LHON carrier with 2 affected adult children.
I'm Paul Laurie. I am affected and have been for 6.5 years.
And we're fortunate to have known our speakers today for many years. Dr. Rustum Karanjia is with us here on stage now. Dr. Chiaramello is in another room updating the broader Mito community about her work on LHON Plus and will join us once she's done. During the next hour, we're going to have a conversation designed to provide an overview about LHON and LHON Plus. Let's start by letting folks know about you, Dr. Karanjia, and your experiences with LHON. Most in the room have found that medical professionals generally have very little experience with LHON, and even most neuro-ophthalmologists have seen only a few LHON patients. Could you tell us about how many LHON patients you've seen, where have you seen them, and what LHON clinical studies and trials have you been involved with?
So my interest with LHON began during my fellowship, my ophthalmology fellowship, which I was fortunate enough to do it at UCLA with Alfredo Sadoun. And through that organization, met Lissa and some other people. And over the years, I've probably seen hundreds of patients who are affected by labors in multiple countries in the US, Canada, Brazil. It's a rare disease, so it's not surprising that most people, even in my profession, don't see patients who have labors. I've been involved in clinical trials for Epi-743, elamiprotide, Gencyte, gene therapy, and peripherally with the LEROS study with Idebenone. So hopefully I can answer some of your questions today.
So let's discuss some things that LHON patients and unaffected carriers often wonder about. Let's begin with the diagnostic journey. What are some of the key differentiating features in LHON, and why do women, children, and older folks struggle to get an LHON diagnosis, even with these symptoms? What is functional vision loss, and why do some LHON patients get that diagnosis along their diagnostic journey?
So labors is classically described as a painless, profound loss of central vision, typically in one eye, followed a few weeks later by the second eye. The challenge in medicine is that when something gets put into the literature, it can take decades for it to get erased or modified. And so the original descriptions of the disease were in young men. And so the literature, unfortunately, has perpetuated that thing that if you are under the age of 26, okay, and you're a male, yeah, you can get diagnosed with labors. But that is not the case. And as we have learned more about the disease, as we've gotten to know about genetics behind the disease, we became aware that it's in women. It can happen at any age. So those things are changing as the generations change, but it takes time. In terms of functional vision loss, it's more or less a catch-all diagnosis of exclusion. It is thought that the patient themselves is either not aware or is aware and deliberately downplaying their visual acuity. It can happen for a variety of different reasons, but the reason that it becomes so common in patients with labors is when a physician looks at the eye of a patient with labors, essentially what they're seeing is a normal eye. And so it becomes harder for them to differentiate that this eye actually has something going on. And until we got more recent clinical tools like OCT, it became a lot more harder, it became a lot easier for us to pick up subtle changes early on in the disease course.
Dr. Karanjia, does LHON cause total blindness?
No. So typically we have an individual who has an area they're not able to see. Part of that area can be in the center or slightly off to the periphery. They have some visual acuity that they're able to read the eye chart for the most part. Some of them may be at 2800, but 2800 is still can be on an eye chart depending on how big the eye chart is that your clinician's using. More commonly in 11778, 3460, usually around that mark. 2400 more commonly in the 1444 community. The scotoma varies though from person to person, and grouped averages don't necessarily reflect things on an individual basis. Some individuals with 11778, 1444, I've seen who've had technically 20/20 vision, but that's not a normal 20/20 vision. They've certainly got areas in the visual field they can't see. They have a new area typically, which we refer to as a preferred retinal locus, where instead of using the macula that's responsible for our central vision for the most part, they're starting to use a more peripheral point. And through that peripheral point, they're getting a better visual acuity, because that's the area they can see better from.
Does LHON cause issues with color vision?
Yes, absolutely. So as we have learned from other diseases as well, the optic nerve contains 1.2 million fibers, but you can lose half those fibers and still be able to see that 20/20 image on the eye chart. Just because you've lost fibers doesn't necessarily mean that you have loss of visual acuity. But more commonly, you end up losing other factors first. So one of the first signs we look for in patients with optic neuropathies is a loss of color vision. It's those color fibers that seem to be more exquisitely sensitive. And central vision loss also comes along with that. Certainly, for the glaucoma literature, you get more peripheral vision loss, but with Leber's, you get more central. Ultimately, both of them results in loss of nerve fiber layer. Both of them results in loss of color vision, and it gradually builds over that time.
What should the LHON community know about Charles-Bonnet syndrome?
So Charles-Bonnet syndrome is a condition where your brain has lost its visual input, and it's trying to make up for that deficit by coming up with something that typically the patient realizes is not real, but is filling their visual field because the brain is starved. It's starved for input, and it's taking the opportunity to make these images and these impressions that appear. Usually they're not considered scary by the individual who's experiencing them. And they're formed in some cases, and in some cases they're not formed. They can be lights and colors and other things happening in the peripheral field. Typically it happens in the area of the field where people are not able to see more and then over the field that people are able to see. And it is more common than we thought. We did a survey recently, and that'll hopefully get published in the next year. And that shows that it's actually quite common in patients who have Leber's.
So, Dr. Karanjia, why don't neuro-ophthalmologists discuss the emotional health of LHON patients and families, and why should they?
So it's a challenge, right? Because you're coming to an eye clinic, and eye clinics classically have never been set up to allow a physician a large amount of time with a patient. Neuro-ophthalmologists typically are allowed the most amount of time when they're interacting with their patients, but at the same time, there are still clinic flow issues and expectations that dictate how our clinics are run, which are out of our control. At the same time, when we are physicians, we learn about different aspects of mental health and other things, but we don't spend a lot of time on that once we specialize. And we don't necessarily become the best person to be able to help you in terms of mental health issues. Certainly in my case, I try to spend time with my patients, but I also try to refer my patients to individuals who have better expertise and more knowledge in those areas, because that's something that I know and I recognize I'm lacking as a skill as a physician.
So people who lose vision to LHON hope to get it back. What do you tell a patient who's been recently diagnosed about what to expect, and what are the factors that impact their odds?
So for any individual, it's hard to predict exactly what's going to happen. And it becomes even harder if you have one of the less common variants. In terms of expectations, the literature suggests that you lose about 17 lines of vision. Some treatments purport a 2 to 5 line gain in vision. But at the same time, that 17 lines lost is still legal blindness, even if you gain 3 or 4 lines. So yes, vision loss is expected. What happens after that vision loss is something that gets a lot more murky and a lot more complicated. We know, depending on the variant, there can be a rate of spontaneous recovery. Those rates change depending on which variant it is. But saying that 70% of individuals get better for 1444 doesn't necessarily mean that you have a 70% chance of getting better. And even if your sibling got better, it doesn't necessarily mean that you will get better. So we don't fully know what all of those things that influence improvement in vision. We know that mutation, age of onset, optic nerve size, and some environmental factors may play a role, but we don't definitely know what those causes are and those links are.
Can you tell us a little bit about environmental factors?
So when we talk about environmental factors, the two things that come to mind right off the bat are alcohol consumption and smoke exposure. And the reason that those two things come up is because reactive oxygen species, which are free radicals that get generated inside our body, the rate of free radical production increases with exposure to excessive amounts of alcohol and exposure to smoke. And when we talk about smoke, we're not just talking about smoking, we are talking about all types of smoke. So forest fires, barbecues, wildfires, vaping, all of those things play a role because they are producing toxins that when you inhale them, they get absorbed into your bloodstream. Those toxins are going to circulate through your body and your body is going to have to clear them. Now, your body has a finite capacity to be able to clear these things. And so if you overwhelm the system, you run into trouble. And it's that balance that gets skewed out of control with exposure to those elements. The other thing to consider is estrogen. Now, the literature is a little bit vague on this. There are studies that have shown that estrogen increases the number of mitochondria that are present inside any individual cell. But how that translates into either a protective effect for women in the sense that women are less likely to be affected, but can still be affected, versus reducing the risk of becoming affected, the juries are still out. But at the same time, if you go back 10, 15 years, women were almost universally supplemented with estrogen when they reach menopause. It's only because of our understanding now that there's an increased risk of breast and uterine cancer and other things that the pendulum swung the other way. So maybe if you have a risk factor like labors, you might want to swing the pendulum back a little bit and consider it at the time of menopause.
Can you talk a little bit about treatments?
So treatment at this stage, particularly in the US, is somewhat limited. The main option that we have is idibinone. That is essentially the only thing that is commercially available right now. There are clinical trials going on for other potential treatments. One of them with the gene therapy, they're looking at running another trial, but the first 3 trials that they did, they're running another one because the first 3 didn't completely succeed. And it hasn't fully answered the question as to whether or not it works. The challenge with the gene therapy studies was that we used a second eye of an individual as a control. And that second eye also improved in vision, even though it wasn't treated. And so trying to explain that and understanding what that means is still an ongoing issue.
So if someone wants to get involved in a clinical trial, what can they do?
So I think one of the things that anybody can do is have a look at clinicaltrials.gov. Most companies and most trials in most countries are required to register on clinicaltrials.gov. Clinicaltrials.org. The studies that are listed there and are usually pretty accurate in terms of where they're recruiting, who's enrolling, and that gives you an access point to be able to go and contact those individuals. Your doctor, even if they're not participating in the study, cannot usually directly tell you about a study. And they cannot necessarily broadcast out that this trial is happening. Because of privacy regulations, they can't give the drug company your contact information, for example. So it ultimately is on you to have to contact these places in order to participate. There are also registries out there that can be quite helpful as well. And those registries can provide that information to you to tell you, okay, there's this new study that's coming up. You might qualify. Maybe you want to get in touch with these people. But again, the onus is always on you to be able to get in touch with them.
If someone sees a trial listed on this site, does that automatically mean you would endorse it?
No, absolutely not. So clinical trials registry online does not mean anything is scientifically validated in any way. There have been studies on there for stem cell treatments, which ultimately are things that I would strongly consider avoiding. Stem cells themselves You can imagine it, you've got a cable that has 1.2 million fibers in it. You're going to put something in the eye, and you want to get that cable to make a connection to something the size of a Brazil nut that's halfway through the brain. Doesn't add up. It doesn't make sense that those fibers are going to know where to go. You've got more real estate inside the brain that's going to do other things that is more likely to get connected to the eye than it is to get to the right place. And so stem cells overall just don't add up for this disease. But they're listed on clinical trials. So the other red flag for a lot of clinical trials is if they're asking you to pay to participate. The vast majority of trials that are associated with good background clinical science will not charge you for the treatment. There may be some cost associated with you going to the center to participate, but they should not be charging you for the treatment, and they should not be charging you for the clinic visits.
How should we think about supplements?
So supplements are an interesting field. If you go upstairs, you'll hear a lot about supplements for treating various mitochondrial diseases. And within the labor sphere, there is not a lot of research as to whether or not supplements make a difference or not. The vast majority of patients, if they're eating a well-balanced diet, a lot of the supplements that you may hear about or consider taking would not necessarily make a difference because you already have the blood levels that you should appropriately have from that diet. There are some supplements out there, though, that can be considered, and certainly they're worth considering if you're deficient in those sorts of things.
Is exercise a concern?
So everybody's body is a little bit different, and certainly exercise increases your energy demands. It increases your metabolism. It is a stressor. But at the same time, your body usually tells you when you're doing too much. If you consider the MS literature, there's something called Uthoff's phenomenon, which is essentially a short circuiting of the optic nerve. The cable itself doesn't work as well in MS patients after they've had optic neuritis. And after that, if their temperature gets too high, they end up noticing that they have some flashing lights and other symptoms that can occur. You can get a similar sort of thing occurring in patients with labors. It's not dangerous, but it's basically saying that you've exceeded the capacity of the optic nerve to be able to deal with the signal that it's trying to send through. And the nerve itself is designed to work within a certain confine, and you disrupt that confine in terms of getting too hot, having too much activity going through it repeatedly, you run into some issues. You've lost that reserve capacity because you've got damage to the optic.
So when there is vision recovery, what does that look like and why does it happen?
So why it happens, I don't have a great answer for. Who it happens to, I have an even worse answer for. But what it seems to evolve about is that you've got this central area that you're not seeing from, and certain parts of it clear up, and you get these little fenestrations in that area. And for some reason, we theorize that it may be that there were dormant cells that were part of that area, responsible for that area, that are now becoming active again. And those dormant cells then provide enough information to get to the brain to be able to provide you with visual acuity in those specific areas. And that opening up is what we think is happening with spontaneous recovery.
So after several years, if someone who's lost vision has not experienced recovery, they often simply stop seeing an eye doctor. They figure they're already blind, vision tests are frustrating, and nothing can help. So why bother? What do you think?
Well, what I try to encourage with my patients is I tell them that, yes, I'm seeing you for your labors, but just because you have labors does not give you a free pass on all of the other more common optic issues with either the optic nerve or with the eye. If you live long enough, you will develop cataracts. That is a foregone conclusion. It is part of growing up. You are going to end up having potentially changes in your retina, which need to be observed and monitored for. The other thing is you've taken a big hit in the amount of fibers you have in your optic nerve. And that's going to set you up to be more susceptible to other diseases that affect the optic nerve as well, including things like glaucoma. So over time, you can accumulate further loss to the optic nerve. And so the idea behind seeing somebody is to monitor for these conditions. If you are losing vision at a rate that is faster than what would be anticipated, then maybe something needs to be done or some treatment may need to be offered. I have a number of my labors patients who are taking IOP lowering or intraocular pressure lowering medication, even though their intraocular pressure is normal, but they have been losing their fiber layer at a rate that I would not expect to anticipate for their age. And so we're bringing the pressure down because that's one thing we can do to hopefully preserve some of their vision.
So getting access to a neuro-ophthalmologist can often be pretty challenging. Can an ophthalmologist or an optometrist follow you? And if so, is there anything we should tell them?
So absolutely, yes. I realize that not many of us in Canada, there are even fewer of us. But at the same time, usually most optometrists and ophthalmologists have never seen a patient with labors. And so then it becomes partially an educational exercise between you, your neuro-ophthalmologist you may have seen once or twice, and the person who's going to be following you in the community. Information is available, and certainly there's information that we can provide as physicians to other physicians to guide them as to what we want to see. I share care with individuals who are optometrists because patients live 6-7 hours away from me. And it takes some time, but I only see them once every couple of years, but I'm able to update their optometrist or their ophthalmologist on things that they need to look for. It's important also to consider that the standard tests that we do in terms of visual field and scans like OCTs, you're hitting a floor effect. You are reaching to the bottom of the scale that the machine is capable of detecting. And so if you do that, you're not going to see any change because the machine is not capable of detecting any further deterioration. So sometimes you have to modify those techniques, change the size of the stimulus, for example, in a visual field, in order to improve the visual acuity or improve the quality of the assessment, I should say.
We've got a lot of sighted supporters in the room. Anything to say to them?
So I would say that they need to get their checkup too, because it's not just a matter of maintaining the visual acuity of the individual who's affected. It's also making sure that the carriers also get cared for, making sure that they are aware of the risk factors. And if we eventually reach a point that we have something that may be able to prevent change or alter change once it starts to happen, being plugged into the system makes that access much easier. You need to make sure that you also will ultimately develop cataracts. It's part of life, right? So understanding that, maintaining your visual acuity, that's an important part.
So what happens over time?
In terms of normal eye health,
No, in terms of affected
in
individuals.
terms of effective individuals. So usually there's a slow decline. That slope is pretty well universal, whether you're affected or you're not affected. That rate of decline, though, is something that needs to be monitored. And if it is happening at a rapid rate, then that's of concern. Cataracts happen for most individuals. A lot of sun exposure increases the risk for age-related macular degeneration, which can affect the central vision as well. If you're very nearsighted, you could have risks for having a retinal detachment. There are a multitude of different things that happen to the eye over time, but we were never designed to live to 80, 90, 100, 150 years of age. Our body does break down. And so making sure that we intervene in the technologies that we have in order to be able to decrease that breakdown is an important part of what we do.
Let's talk a little bit about unaffected carriers. Most of the literature says an unaffected male has a 50% risk of onset. What are your thoughts?
So a lot of these numbers are generated from looking at pedigrees. And some of those pedigrees were found or identified early on when we just were learning about how this disease transmitted from one generation to the next. And so it's not surprising that those pedigrees maybe had a higher rate of individuals becoming affected. When you start looking at genetic testing and more access to the genetic testing, we're finding more and more people who end up having one of the variants that are common, but have absolutely no visual symptoms and have no family history of visual symptoms. So the denominator, that number at the bottom, is increasing all the time. And so that 50% rate in more recent studies is down to about 17% in some cases, and we're down as low as 2%. So as we learn and understand that more and more individuals potentially carry one of the variants that can cause labors, we come to understand that this is maybe more common than we think as carriers, but the rates are also dropping as a result.
Can unaffected carriers impact their risk of onset?
Yes. So certainly avoiding smoke, avoiding alcohol, excessive alcohol consumption are two of the main things that I would recommend in terms of the environmental factors. Consideration of estrogen therapy, weighing the risks and benefits for you individually is something that you need to do with your family doctor or your gynecologist. I would not recommend taking idipinone. There is no evidence to support the use of idipinone in a carrier at this stage. And there's also still some concern that if you are a carrier, your body has reached a certain homeostasis where it's reached a balance between its ability to deal with having a variant that could potentially cause vision loss and maintaining your vision as it is. And if you start playing around with that, there's a possibility that you're going to disrupt that homeostasis and potentially you could accidentally trigger vision loss, either by being on a medication or withdrawing from a medication. So we don't know any of that. There are no studies to back up any of that information, but it is a theoretical risk. And it's something to consider if you're trying to do something preventative. It takes a lot of people and a lot of money to come up with an answer. And unfortunately, we don't have those answers.
Can you talk a little bit about females and LHON?
So the original paper that Labor published back in the 1800s specifically said that it's a disease of men. And that is something that has been fought against for almost generations now. We've come to understand that women can be affected. And in one of the papers that we published, there were over 1,000 subjects, and we found that women made up almost 25% of those that were affected. We didn't see the same peak that we see in males in the second decade of life. But both groups could be affected from pretty well when we could find out that they couldn't see properly in childhood all the way up into 89, I think is the oldest subject that we have identified so far at time of conversion. So it can pretty well cover the whole gambit.
Thank you. So we're going to turn for a minute to LHON Plus. And while most people associate LHON with sudden onset vision loss, LHON is caused by a mutation in the mitochondria. And we have mitochondria throughout our bodies. And some people with an LHON mutation have non-ocular or non-vision symptoms that are more commonly experienced in other mitochondrial diseases. Many people in this community know Lisa Mito, who created and leads our LHON Plus Facebook group and personally helps everyone with non-ocular symptoms. I met Lisa at the first LHON conference in 2013, and she's kept LHON Plus top of mind for me ever since. Just prior to the 2018 LHON conference, Lisa let me know she'd read an article about it, and she'd reached out to one of the authors and had had a good conversation. Lisa wasn't able to attend that year's conference, so she asked me to meet with Dr. Chiaramello and her co-authors there. So Dr. Chiaramello, thank you very much for joining us. And could you tell us a little bit about that and how connecting with Lisa and the LH1 Plus community has impacted your research?
Well, thank you. First of all, thank you for inviting me to this conversation, very important conversation. And I'm sorry, I feel like I crashed a party because I came late, but it's because I had like a conflicting schedule. I was giving like a presentation at the clinical science session, clinical trial session at the UMDF. So I'm very happy to crash a party, and it's always a very difficult choice to follow Rustum because I mean, he's an excellent speaker. So I'm going to try my very best to match him. So to come back to Lisa Thompson, she's terrific. Some of you met her via FaceTime yesterday when with a table I did yesterday. And it is true that in a way I felt like she stalked me a little bit in that time because I published the very first manuscript on LHON MS, so the extreme case of LHON plus. And I received an email late in the evening, and it was from Lisa Thompson, where she had a series of very smart and challenging questions. So I decided, well, I'm going to answer them right away. I mean, because it was only 11 p.m. What do you do in Washington, D.C. at 11 p.m.? Not much. And suddenly she responded immediately because she was 3 hours behind. And that's how we started the conversation. And I've been in touch with her all along now. And I've done a lot of things with Lisa. not only on a patient-related aspect, but also on educating future medical students. And I thought that they need to hear from Lisa because she's one extremely articulate. She's extremely knowledgeable on LHON Plus. And if anyone can convince some medical student that it's worth their time just to study mitochondria, it would be her. So for me, it's say, okay, just because they need just to have a good grade from me. But from her, as a patient advocate, she had a major impact. So, and hopefully with the new technology, I can do that more often because yesterday, for example, she's so dedicated, she did that from her hospital room. So they were so interested in her and accommodating her that they even gave her a private room just to do the FaceTime. So I thought it was really great. And see how convincing she can be? So I met her and I was she was instrumental for me just to add on another disease because originally I was studying MILAS. It's a mitochondrial encephalopathy disease. And she said, you know, maybe you should consider LHN plus because maybe there's some overlapping mechanism between the two. And she had a good point because that's how, I mean, it all started. And like see a simple innocuous 11 p.m. discussion at night led to funding from the Department of Defense and now from NCAT. And now we have this clinical trial that is going to get started in late August, early September on those two diseases. So you can see how persuasive she can be just to take on even more work.
Dr. Chiaramello, what symptoms do you hear about from LHON patients that are associated with LHON plus?
Oh, very good question. Because I mean, that's going to be difficult to answer precisely because each patient is different. You know that there's a lot of clinical heterogeneity, even among family members. So less, even more among like a white population. But usually the very first thing that giveaway is that muscle weakness, where you start having like a hard time walking. So that means that and then you can no longer carry your day of work as usual because you have extreme fatigue. So it's accompanied with what we call chronic exhaustion, and it's not to be neglected. And because for anyone unaffected, they do not understand what it is to be chronically affected. So actually, it's a discussion I just had like recently with Lisa Thompson because one of her residents couldn't understand it, and she said, "What can I say?" And say, "Oh, okay, let me be the hammer. He's going to understand it. It's just tell your resident that he's going to run a marathon, and then as soon as he goes through the finish line, no, we don't want to see him. He's going to start a second marathon, and how will he feel? He's going to have a mito crash. So that's the extreme fatigue we're talking about, and nobody kind of accentuate that, but I think it's really the precursor sign that there's other symptoms. Other symptoms, additional symptoms associated with LHN plus or gastrointestinal dysmotility that it's not very much studied, although now, I mean, with the clinical trial is going to change. And there's also tremors. So it starts with a slight tremor that you say, oh, maybe because I was tired, because I have muscle weakness, and then it gets amplified along. And then there's also cardiac problems, conduction defects, cardiomyopathy. So that tells you immediately that you need like to increase your panoply of physicians. And what else is dystonia, which is when the muscle kind of lock in place and you cannot unlock your muscles. It's very painful. Seizures. But, you know, I'm giving you all a panel of symptoms, but you don't expect all of them to be expressed all at once. Thank God. I mean, otherwise, I mean, that would be really, really, really bad. So maybe in some patient that will be converting from LHON to LHON plus might start having essentially myopathy and peripheral neuropathy. Peripheral neuropathy is really painful and especially aggravated for those people living in a cold climate where you have like pins and needle under the sole of your feet, numbness in your hand. And that is extremely painful and there's not much we can do about it. So, but it needs to be reported. And that's when you start converting from LHON to LHON plus. Let's not forget, those are progressive neurodegenerative disease. So you have some patients that will remain always LH1, and some people that actually start with LH1 plus, and some people that will convert to LH1 plus, and some among the LH1 plus actually have no optic neuropathy, but we start with the extraocular symptoms. So it's a really a big basket of different flavor, and that makes it really difficult for the patient to acquire the right clinical diagnosis. So that requires really good access to specialists.
What diagnostic tests should LHON patients discuss with their doctors?
Genetic testing, if they haven't done that. And I think it might be a problem in, I don't know in Canada, but actually in the United States, it might be a problem with the health insurance, because you have just to demonstrate that you really need it for them just to do it. So I always feel like, how am I going to do that? It's not a smart person saying that. That's impossible, because you need just to be diagnosed, genetically diagnosed in order to have a clinical diagnosis. And they're telling you, no, get the clinical diagnosis and then we'll do the genetic diagnosis. So that's the only test right now that is that can confirm whether or not you have like the mitochondrial disease, like LH1 or LH1 plus, and all the others. The other tests are so unspecific that I will not even waste my time to lobby with your health insurance company, but because we're still making progress. So there's not much access other than the genetic test.
So how can people with non-ocular, or as I think you put it, extraocular symptoms find doctors that understand their situation?
It depends where you live. So if you live in a big city, I would suggest tapping into the university system where you have research going on. And then because I think that if you look at the map, actually I did like a PowerPoint on that once. When I did the map, and I realized that, my gosh, there's nothing in between the West Coast and the East Coast. The East Coast corridor is full of it, all the way down to Florida. Then you need to skip you need to skip all the way to the Rocky Mountains in Denver. And there's some in Arizona, Minnesota. That's about it. Oh, Washington, the state of Washington. Yeah, of course.
California, a
Yeah,
little
and
bit.
California.
Yeah.
California excluded because you have everything over there. So sorry, Paul. You're so rich over there that you can have access to anything. But for the patients that are kind of stuck in between, that's the difficulty. So I think that I would just try to find a good general physician with whom you can have a dialogue, and I can orient you toward like specialists. In terms of specialists, I would recommend for patients with LHN plus with extraocular symptoms or cardiologists definitely, and neurologists. Of course, you all know ophthalmologists, but no ophthalmologists are great, but that's all they do, the eye. When actually you have just to look at the disease on a systemic point of view, meaning that it tackles more than one organ at a time. So those are the two big specialists I would recommend.
Is the UMDF a good source for people to use to maybe get connected to doctors and throughout the country?
Right, they are. UMDF is a good source because they always organize the doc is in, and so usually they are more in tune with those patients. For example, I had like my former collaborator, Dr. Andrea Gorman, that many of you might know, and she was at Children's National Hospital in Washington, D.C., and was recently recruited by St. Jude Research Hospital. So now she said she's going to take the southwest portion of it. So maybe that will just fill in the gap. So that's, but you can get access to the list of the doctors and specialists from UMDF. That's a good idea, yeah.
Have patient and people used MitoAction to find providers that might help them in their LH1 plus situation, or
I don't,
complex mito situations?
I don't know. I usually stalk people. So, I mean, I would just like go straight to the top at the UMDF, and because then it's best just to ask the one in charge, and they can direct you. So I'm not sure about mito share or mito action.
That's great. Thank you, Dr. Chiaramello. Dr. Karanjia, many of us in the LH1 community have heard that we or our loved one might have MS when perhaps it's not truly MS. How does that happen and how do we get clarity?
So when somebody typically presents with the vision loss aspect of LHON, they're usually misdiagnosed as having something called optic neuritis. And all that optic neuritis means is that there's inflammation in the optic nerve. It doesn't necessarily mean a specific disease. The differential for optic neuritis includes labors, but it's pretty far down on that differential. And from an optic nerve
What's the
perspective,
differential? I'm a patient.
sorry. Differential diagnosis is a list of all of the possible conditions that could be
Mhm.
as a result of those symptoms. And so you start off with the things that are most common. Those are the things you push up to the top of your differential diagnosis. And the things that are rarer and rarer and rarer go down and down and down and down on the list. The other thing that impacts the differential list are going to be treatments. If there are things that you can treat and time is of the essence, those are the things you're going to push to the top of the list because you want to intervene quickly and rapidly because that's going to prevent further vision loss. The things you can't treat, those start dropping down lower and lower and lower on the dust. So you build this differential, and all physicians do it when they see a patient, and then they pick, okay, these are the symptoms that you're having. You lost vision in one eye. You have signs that I can objectively determine that you have a decrease in vision in that eye. And that can be through doing clinical tests, or that can be through examination time. And then with that, what is my most likely diagnosis? Because when I look at the back of your eye, it looks normal. And then in that situation, number one on that differential is going to be optic neuritis. Now, optic neuritis can be associated with MS. It can be associated with other diseases. NMO and MOG are two other things that you might have heard bounced around, but they're all different types of inflammation in the optic nerve. The usual thing that happens next if you get diagnosed with optic neuritis is that somebody will give you high-dose steroids. The reason for that is because we did a study about 25 years ago that showed that if you gave high-dose steroids, you decreased the likelihood of developing MS. Now, that study has somewhat changed as we have gone further and further out from it. The 15-year data from that original cohort showed us that actually looking at the MRI was the most important thing because that told us whether or not you were going to develop MS. And whether we treated you or not, the risk of that reoccurrence didn't really seem to play into it. Now we've gotten to a level where there are other diseases that if we don't treat them, the chances are visual recovery is not going to happen like it does for those patients who have optic neuritis associated with MS. So now we're starting to treat more and more aggressively. And so in those situations, patients might have IV steroids. IV steroids don't seem to improve the vision. The doctor gets concerned, sends you to get IVIG, or they send you for plasma exchange or PLEX. These are all stepping up those therapies, but going down that same pathway of optic neuritis. And quite often, it's not until the second eye that becomes involved that the shoe drops and people think, oh, this might be Leber's. The challenge is that sending you for a genetic test is going to take weeks. And I'm not sure how it is in the US, but they batch these tests, right? They don't, if you send the test in, they don't do the test instantaneously. They wait until they get a whole bunch of requests from different places, and then they put it all together and they run it through the machine in one go. So depending on if you were the last test to get in before they ran it, or if you're the first test to get into before they ran it, it could be a month or 2 months before you actually get a result. Okay. And so getting that result at that point, if you did not have Leber's, but you had optic neuritis, you've lost that window to treat. So that's why doctors become very aggressive in treating along that optic neuritis pathway. Now, when it comes to the more systemic issues, I'm sure Dr. Chiaramello is going to be more knowledgeable to be able to speak about that. But what I will say is that you can have both MS and optic neuritis. It's possible to have a common disease with a rare disease. Happens more times than we might think. And if you look at some of the literature for those individuals who actually have MS and are associated with optic neuritis and have Leber's, they're not two distinct pathways that they follow. Their MS is influenced by the Leber's, and the Leber's is influenced by the MS. So I have patients who have had the optic neuropathy happen after what would be classically considered an episode of optic neuritis that responded to steroids that was associated with their MS, but subsequently they had another attack and then their vision declined and didn't recover. So there are cases like that. And so this overlap is not two distinct entities, two distinct things that don't influence each other. You're a single human being. All of the diseases you have are going to influence each other.
Why should,
May I mention something
Please.
here? Actually, the LH1 MS was originally known by as the Harding disease because Dr. Harding was the very first physician to describe this disease. But then, you know, it was before all the genetic testing, so she didn't know that that mutation associated with LH1 was responsible for the disease that wears her name, so the Harding disease. And then little by little, we drifted from Harding disease to LH1 MS. So, and when you question medical students, say, is Harding disease the same thing as LH1 MS? The answer is no. So it's really a shocker because it doesn't matter how many times you say they are going to remember LH1 MS instead of Harding disease. So it gives you an idea that it's really important just to, one, give credit where credit is due to Dr. Harding, and then just to try to bring it back to the original description of a disease that included also, like Dr. Karanjia said, like a systemic expression of the disease in other organs. And that's what she described very perfectly.
in terms of patient participation in the process, we often are asking folks in this room and elsewhere to provide data, providing contact info, providing data into a data collection program, providing biosamples. Should we? Is there a reason for a patient to take the time to do any of that?
Should we what?
Provide data, patient data, to gather data about patients in repositories. Does that help researchers in any way?
I'm concerned about HIPAA here because we know especially when you live in Washington, D.C., you get nailed by HIPAA. So, and you're out of bounds, you're out. So
I think it's a challenge for us as physicians to do those sorts of data
Mhm.
collection. Those restrictions don't apply to organizations like LHON.org or UMDF
That's right.
because they're governed by different criteria. And as a physician, I can't share your medical information with anybody without your explicit consent or unless it's part of your circle of care. Whereas these organizations have the ability to compile that data and then be able to de-identify that data and use it in ways that are quite helpful. One of the challenges we've had with the vision side of Leber's is that we cannot really run a lot of clinical trials anymore because of the wide availability of Idibinal. And so we run into a situation now where we don't have a good control group.
Mm.
And if we don't have a good control group, it becomes much harder for us to know whether or not a therapy we're trying is actually working. So, for example, the LYRA study, which was the most recent Idibinal study, used a series of historical controls. Now, anytime you slap that label of historical control on something, you're going to run into some problems. And part of that is just by the nature of the way the data was collected. I don't know how many of you have been to your optometrist or ophthalmologist and been in there and somebody's put up the eye chart and shown you the largest letter they have on their eye chart and then just said, oh no, you can't see that. Okay, I'm just going to write down you count fingers, right? Or they're just going to write down, okay, you can see my hand motion. They don't really do much more than that on a classical basis because there was never any need to do anything more than that. But if you want to know whether or not somebody's vision is count fingers at 1 foot versus count fingers at 3 feet, that actually makes a difference. And that information is important because it has to be captured somehow so that we know what the natural history of the disease is, so that we know and understand what's going on. And having these databases of patients who are outside of the medical system is probably one of the ways that we're going to be able to do that. The other advantage of being part of one of these registries is that if something comes up in terms of a clinical trial, it's much easier for LHON.org or UMDF to reach out to people and say, you carry this variant, maybe you want to get in touch with this person. Hospitals are really cumbersome places, and HIPAA makes them quite restrictive in what we can do.
Okay.
Well, that's a problem, especially when once a study is federally funded, then then the lid is even tighter.
Exactly, yeah. Clinical trials, the restrictions associated with it.
Yeah.
I used to sign my name. So in Canada, we write the date, the month, and the year. In the US, you write the month, the day, and the year. If I sign the wrong way, I have to cross it out and re-sign it, right? Like that level of fine detail they worry about.
Thank you. So we've got 5 minutes and then we're going to change to our next session. And Tim has a microphone and we have time for like 1 or 2 or 3 questions max. Tim, there's hands in the, Tim, you have one there? No? Okay.
Hi. Is this on? Okay. So my name's Susie Scheller. I'm with Vital Sign Fertility Care Center, and we have found the continuous glucose monitor is helping us determine some underlying causes from some symptoms that overlap here with people who are struggling with women's health issues. And I am wondering because generally we can teach women who are blind to do our method, but there's a connection with the retina and insulin and glucose, and then there is with the endometrial lining. And I'm wondering, is anyone in the LHON community using continuous glucose monitoring to deal with symptoms? Just to give you one example, we had a woman come in, she had a healthy birth, she had a miscarriage. For us, a miscarriage is a biomarker for looking for further things. And then she had dry cycle, no ovulation activity. We test and she had high cortisol. And then we tested further and we were able to pinpoint a pituitary tumor very quickly. And she's had that removed all within just a few months. Is that continuous glucose monitor, can that help pick up these things that accelerate or allow for recovery? Is there any play with that?
I think it does, but you hit like the mystery box here. So, and there's one potential symptom that nobody talks about is called placental insufficiency. And that's really important because, and it's under-recognized and underrepresented and under-discussed and underfunded. But for women affected with some, or carrying a variant, pathogenic variant, it's reality here. And I think I've done, an article on that, and I'm in charge of a book. So I try to bring awareness on placental insufficiency because it's really detrimental to the parents.
Did we have another question out there? Tim?
I'm Erin Cox and my husband is Neil Cox and he's been affected for 13 years. So his sister is a carrier. She has 2 boys. And she would like to know about the air quality with the Canada smoke, like how important it is to keep them in her 2 boys in at times. Could it be strong enough to trigger if they are out just for a baseball game? Also curious about ozone air quality. It's been bad lately. Is that something to worry about? And then finally, the vitamin B12 confuses her. She's read to stay away from the cyano one, but also that deficiency can trigger. So some clarification.
So cyano versus carboxy and vitamin B12. Usually you can get the other variant, so it's not so much of an issue. The issue is the concern that cyanide, which is part of that cyanocobalamin, or the cyano version of B12, is potentially toxic to mitochondria. The challenge is there is no published clinical case or any demonstration that it has caused an issue. So overall, if you're B12 deficient, yes, if you had a choice, I would take the one that is not cyano associated. It's not synthetic, therefore it's also more expensive, which is why usually you end up with the cyano variant. In terms of fires, there are cases that we are aware of where patients became affected after exposure to prolonged periods of poor air quality and smoke. There's a published case in the literature of a family who was affected in 3 generations over a short period of time, and they were living downwind from a tire fire that didn't go out for a long period of time. So certainly smokes does play a role in that. There are also cases associated with the wildfires that happened in California a few years ago. We've seen cases in Canada that are potentially associated with the wildfires that were seen in northern Quebec a couple of years ago. So yes, there's an association with smoke. What can you do to mitigate it? That becomes a bit of a challenge depending on how old you are and what you're doing. I have in the past for some of my patients given them a no medical certificate to say that they cannot be outside during times of extremely low air quality. And I view that as being no different from somebody who has asthma and is unable to go outside because of extremely low air quality. It's a risk for that individual's general health. So providing that note is something that I am happy to do for my patients. It's something that you need to consider within your own medical circle of care.
I like to echo Dr. Karanjia's message here, because there's risk, but the risk is determined also by an unknown, which is called the nuclear genome, because mitochondria are semi-autonomous organelle, so they don't function on their own. They function in collaboration with the chromosome that you have in your cells. And we each have a different genetic background and epigenetic layout. So it's really difficult just to assess the degree of the risk that you can take. So there are some patients say, well, nothing happened to me. But would you, the question would be, would you take the risk of something happening to you without knowing it? So I think that the approach of Dr. Karanjia is really wise, that, you know, in this case, since we cannot assess the degree of risk, you're better off eliminating or diminishing that risk as much as possible.
So I realize we are at the end of the hour. We must stop. I want to thank both of our speakers today for their time and insights. And Dr. Karanjia will be with the LHON group in and out throughout today and this evening at the reception banquet for those in that arena. So if you didn't get a chance to ask a question, you may find him during a break or at lunch. And Dr. Chiaramello is here at UFMDF throughout. So you'll find her throughout the hallways. So yep, please seek them out. And thank you again so much.
Thanks, everyone.